Welcome to video 2 in this first of 3 lessons that cover primarily the heart, but are really meant to be an introduction to the cardiovascular system. In the first video, I sort of introduced to you the concept that I'm trying to get across here, and as I told you, there are only certain things that I expect you to study, but I expect you to be familiar with all the material that I go through here. So first of all, the cardiovascular system supplies the entire body with oxygen and nutrients and removes waste products. It does this by circulating blood, which picks up and releases these products in the appropriate organs. The heart is a pump. It pumps blood. It shoves out blood, which of course is a fluid, at a cardiac output of about 5 liters per minute. That is 10,000 liters per day. That is 4 million liters per year. Your heart never stops, and it works extremely hard. And because it is supplying itself with oxygen and nutrients, it presents some very unique problems when it comes to understanding heart disease and treating it. It is one of the 2 most important organs in the body. If you were to start to bleed out and hemorrhage, your body would shut down blood flow to your organ systems one by one until all that was left was your heart and your brain. And then it would finally shut down the heart in a last-ditch effort to get a little bit more blood to the brain. Your heart would slow down. But you are in deep, deep, deep trouble at that point, obviously. The cardiovascular disease, the most common cause of death in the U.S. and the world, and has been so for some time. What drugs will you use to treat the cardiovascular system? Digitalis would be one. That is probably one that you have heard of before. It inhibits the sodium-potassium pump, which we are going to talk about. All of these drugs, including this one, they are an example of why you need to know the macroscopic components of a disease and how they relate to the microscopic components of the disease, that is, the proteins and so on, and how changes at the protein level and the membrane level are transformed into changes on the microscopic level. That is how they result in changes that you actually see in your patient, like an increase in heart rate or something. Okay, and if you want to understand how these drugs work, you have to understand the relationship between these 2, and you need to be able to go up and down the ladder, down from symptoms to microscopic problems that are causing those symptoms, up from treatment of those problems, which almost always happens at the microscopic membrane and protein level. You need to know how changes on that level, you often with treatment with drugs, result in macroscopic changes, things that you will actually see in your patient that might, for instance, indicate that he or she is getting better. Okay? So, sure, you could memorize the effects here. Number 1, that's dangerous. Number 2, that wouldn't make you much of a doctor. Doctors really should understand how the drugs that they're administering work, or at least they should have understood it on some level at some point. Because once you start adding a bunch of drugs together and they start interacting, the only way to predict what's going to happen is to understand how the drugs work and how they're going to interact on that level. That will be the pharmacologist's problem to teach you. My problem is to teach you how these components relate and why it's important that they relate. That is physiology in a nutshell. All right? Sympathomimetics, dopamine, dobutamine, these mimic the effects of the sympathetic nervous system, which I am going to take you through in these lessons. They act through G-coupled receptors to ultimately modulate ion channels in intracellular second messenger system. This is microscopic. And obviously, you need to understand how this works if you want to understand how the drug results in changes that you can see in a patient. Phosphodiesterase inhibitors like amrinone inhibit the breakdown of cyclic AMP. We will talk about that in great detail. Calcium channel blockers, as I mentioned in the first video, calcium causes an increase in force of contraction. That causes your stroke volume to go up. That causes your cardiac output to go up. And so calcium channel blockers will not help you with that. You hope that they won't affect that much, but that is a side effect that you should be aware of. What they do is they block calcium channels in smooth muscle as well as cardiac muscle, and that causes the smooth muscle to relax. That relieves hypertension. So this is a drug that you'll use, for instance, perhaps to treat hypertension. It also has side effects depending upon which channel blocker you're using on the heart. You need to be aware of those. Beta blockers block the effect of the sympathetic nervous system on the heart, and you will see that those are invaluable for the treatment of heart disease, and you will learn why that is. And antiarrhythmic drugs work on the level of the ion channels. Once again, the importance of understanding these channels and how they work, how they result in the generation of an action potential, how that action potential propagates around the heart, and how alteration of the activity of those channels can alter the way that propagation happens and either cause or relieve arrhythmias. This is something that we will be teaching you in some detail during this block. And in order to understand it, you have to understand how the channels work. Okay, so the heart. 4 chambers: right atrium, left atrium, right ventricle, left ventricle. They are separated by valves. The right AV valve is the tricuspid valve. It separates the right atrium from the right ventricle, called the tricuspid valve because it has 3 leaflets. The left AV valve, AV stands for atrioventricular, separates the left atrium from the left ventricle. It is called the mitral valve. It has 2 leaflets. And finally, we have the semilunar valves, the pulmonary valve, which is at the entrance of the pulmonary artery, which exits the right ventricle, the aortic valve, which is at the entrance of the aorta, which exits from the left ventricle, okay? And these are your semilunar valves, okay? The way blood flows through the heart. During diastole, your heart is relaxed and it is filling with blood. So blood enters the right atrium from the vena cava, and it flows from the vena cava into the right atrium. Blood flows from high pressure to low pressure, and that means that the pressure in the vena cava is higher than the pressure in the right atrium. It is not much higher, and in fact, it may be very, very difficult to measure, but it must be higher because blood will not flow if it is not, okay? High pressure to low pressure, vena cava to the right atrium. And then, because this ventricle is relaxed, the pressure in that ventricle is low, the right ventricle, and blood flows from the right atrium down its pressure gradient into the right ventricle through the tricuspid valve, which is open at this point, okay? So blood is flowing into the right ventricle. Now we begin systole, which means this heart starts to contract, okay? The muscle contracts, and that causes the chambers to contract, and the pressure goes up. And when the pressure goes up, the pressure in the right ventricle exceeds the pressure in the right atrium. And that blood wants to flow from the high pressure to low pressure back into the atrium, but because this pressure has been elevated, this valve is a one-way valve and it is shoved closed. The leaflets are shoved together. This valve closes, and although blood wants to flow from the ventricle to the atrium from high pressure to low pressure, the valve prevents that from happening. Instead, the pressure rises in the right ventricle and it exceeds the pressure in the pulmonary artery. Now, up to this point, during diastole, the pulmonary valve has been closed. But when the pressure in the right ventricle exceeds the pressure in the pulmonary artery, blood wants to flow from high pressure to low pressure, and it flows from the right ventricle into the pulmonary artery and out into the pulmonary circulation. Okay? Okay? Now, we've ejected blood from the right ventricle. Let's see what's happening on the left side during this cycle. So blood goes from the pulmonary circulation, and from the pulmonary veins, it enters the left atrium, flowing from high pressure to low pressure into the left atrium. Okay? This is diastole, the muscle is relaxed, and so the pressure in the left ventricle is low. Blood flows from left atrium to left ventricle, from high pressure to low pressure during diastole. During systole, the left ventricle is contracting. It's contracting at the same time the right ventricle is. And on the left side, that contraction, just like on the right side, it increases pressure. And pressure, the pressure in the left ventricle exceeds the pressure in the left atrium. Blood wants to flow from high pressure to low pressure, but these leaflets are shoved closed on the mitral valve, and blood is prevented from flowing down its gradient. So it wants to flow from here to here. The valve closes, is shoved closed, and it does not do so. The pressure in the left ventricle rises, and the aortic valve, which was closed during diastole, now opens because the pressure in the left ventricle exceeds the pressure in the aorta, and the valve opens and blood flows from high pressure to low pressure into the aorta, okay? And from there it enters the systemic circulation, where it is returned to the vena cava. So these are the two sides of the heart. These things are happening simultaneously, but you can see how, let's say, an aliquot of blood flows to the right side through the pulmonary circulation, is now returned to the left side and enters the systemic circulation. What you're seeing is the life of the typical red blood cell. Okay? All right. So things that can disrupt this process, there are many things. I'm going to focus upon what can go wrong with the valves. We have valvular stenosis, which means a narrowing of these valves, and if they narrow, then they slow blood flow, and that can be a problem. And then we have valvular insufficiency, where these leaflets don't completely close, and where blood can actually leak back into the atrium, or if it's the aortic valve or something, back into the ventricle. All right? So let's take a look at how this all works on an electrocardiogram. So this is an electrocardiogram. What you see here is the left atrium, and this is the left ventricle, and this is the aorta, and up here is the right ventricle. For now, let's focus on the left. Again, the first thing you might notice, I mean, I'm not a cardiologist, I don't pretend to be one, but I know that the heart's not supposed to be the size of a basketball. And this is a very enlarged heart. Now see this color here? Those are swirls of blood, and they're being caused by blood ejecting at high velocity back through the valves when it shouldn't be. So notice this valve, this is the aortic valve, and you can actually look, if you look closely, you can see these leaflets separating. And when they're separating, that means blood is being shoved into the aorta. That is a good thing, you want that. But notice this color appears when these leaflets come together and are closed. This is blood leaking back through the aorta, through the aortic valve when it shouldn't. Ordinarily, when this valve closes, it closes to prevent blood from flowing back from the aorta into the ventricle as the ventricle is relaxing. That is not happening here, so this is an insufficient aortic valve. Okay? The same thing on the mitral valves here. See the two leaflets coming together? And this color appears when the two leaflets come together. You're not supposed to be able to see that on an echo. This was done with the Doppler turned on so that you could see this swirling motion, okay? This is called turbulence. You can actually see that this appears when these leaflets come together. That's not supposed to happen. When these leaflets come together, the valve is supposed to be closed and it's supposed to be preventing blood from flowing back into the atrium. You can see in this patient that that's not happening. Valvular insufficiency, fairly common in dilated cardiomyopathy. That is what's happening here. This is physiology gone bad. Okay? All right. So this patient had a holosystolic murmur. And the reason she had a holosystolic murmur is because of that turbulence that you just saw. When blood flows back through an insufficient valve at high velocity and you get this turbulence, this swirling, that causes the walls to vibrate in the heart or in the aorta, depending upon the murmur. And her holosystolic murmur is being caused by these insufficient valves and that swirling that you saw, that turbulence causing the walls to vibrate. And that's what you hear in a murmur in the heart, okay? Okay, so I expect you to know and take away from this lesson how blood flows through the heart, what we just went through, okay? This is just exactly what I said, okay? All right, that's the end of this video, and from here we will progress on to the next video. Thank you for your attention.